Hi, folks, this is James, and today I want to thank you for joining me in the discussion of adrenal insufficiency, a disorder that occurs when the adrenal glands do not produce enough aldosterone, cortisol, as well as weak androgens. So, not wasting much time, let's dive into it. All right, so adrenocorticotropic hormone, which I would refer to as ACTH, plays a critical role in regulating the functioning of the adrenal glands. Here I'm talking about the adrenal cortex, which is divided into three distinct zones. Zona glomerulosa, which produces mineral corticoids such as aldosterone, responsible for salt and water balance in the body. The middle zone, called zona fasciculata, is responsible for the secretion of glucocorticoids such as cortisol, which is known to regulate stress response, glucose metabolism, as well as known to play a role in immune suppression. The innermost zone, known as the zona reticularis, produces androgens, that is, the sex hormones. So the term primary adrenal insufficiency means the origin of the pathology is within the adrenal glands, hence ACTH levels will be elevated. Now recall that in primary adrenal insufficiency, the adrenal glands are unable to produce enough cortisol due to the failure of the glands. So the pituitary gland releases more ACTH in an attempt to stimulate cortisol production. In contrast to secondary adrenal insufficiency, that may span from a disorder in the hypothalamus that causes a decrease in corticotropic releasing hormone, or a disorder in the pituitary gland that causes a decline in ACTH levels, would affect the adrenal cortex. Now, this is important because when we talk about skin pigmentations or mucosal pigmentations, this is known to happen in primary adrenal insufficiency and not in secondary because of the elevated levels of ACTH. Now, regarding the regulation of the zona glomerulosa, which produces aldosterone, it appears that ACTH plays a little role, but physiological regulators of aldosterone productions may include potassiums as well as angiotensin 2. These factors here may affect the maintenance of the zona glomerulosa, that is, the production of aldosterone. Now, it's clearly not a secret that adrenal insufficiency is a low aldosterone state. You recall that aldosterone is necessary for sodium water retention, but in the low aldosterone state, there is a low sodium water retention that in fact leads to a shrinkage of the vascular compartment. The volume decreases. This causes a decrease in the stroke volume. A stroke volume decline would also imply a low cardiac output, and this will cause hypotension. So the blood pressure drops, and it can be significant enough to cause hypoperfusion of vital organs. So the kidneys, the brain, and the intestines may all be involved. The kidneys may be affected because of pre-renal azotemia due to a poor renal perfusion that eventually can evolve into an intrinsic renal failure as a result of, say, acute tubular necrosis. So patients may exhibit signs and symptoms of acute renal failure. They may also have signs and symptoms of cerebral ischemia and intestinal problems as a result of the ischemia. So it has been said that any patient who has an unexplained abdominal pain or vomiting, there should be a low threshold for considering Addison's disease. Now, the hypoperfusion may be strong enough to even cause a shock. So, regarding the volume contraction, patients would also become very dehydrated, and that can cause an electrolyte derangement. So, we're talking about sodiums, so there might be a low sodium state. What about potassiums? The potassiums will be elevated. So, normally, a typical patient with Addison's disease can be described as weak, tanned, and lean. But patients may also complain of easy fatigability, myalgia, arthralgia, anorexia. These are partly due to release of cytokines as well as a decrease in the cortisol levels. Now, in primary adrenal insufficiency, the low cortisol state leads to excessive synthesis of ACTH as a feedback mechanism. ACTH in excess can stimulate melanocortin 1 receptors and cause hyperpigmentation. Melanocyte stimulating hormone by itself is a byproduct during the synthesis of ACTH, which can also cause hyperpigmentation in the form of a dark bronze color in palmar creases or the mucosa of the body. Hypoglycemia in Addison's disease. Cortisol helps regulate glucose levels in the body by stimulating the liver to release glucose into the bloodstream. Now, you do recall that cortisol is a catabolic hormone which causes proteolysis, a breakdown of proteins. Now, in that process, there is a formation of glucogenic amino acids. These amino acids are used by the liver to make glucose in a process called gluconeogenesis. Excessive cortisol would also antagonize insulin and help with the stimulation of the production of glucagon. Hence, excessive cortisol will lead to hyperglycemia. Now, in contrast, and without enough cortisol, the liver does not release enough glucose. Moreover, the low cortisol state would leave insulin not inhibited and also a decline in the glucagon levels. Hence, a patient with Addison's disease is likely to suffer hypoglycemia. Now, it is clear that a low aldosterone state would lead to a decrease in the sodium water retention. In other words, there will be a decrease in sodium reabsorption. You do recall that aldosterone binds to a mineralocorticoid receptor and that activates a gate called epithelial sodium channels. When these channels get activated, sodiums are reabsorbed, but in a low aldosterone state, these channels will certainly not be active. So, in other words, there is going to be a decrease in sodium reabsorption. Now, this would lead to an impairment in potassium secretion. In other words, the potassiums and hydrogen ions would remain, and that would lead to acidosis, something that we see in Addison's disease. Now, Addison's disease may be associated with the following disorders: vitiligo, thyroid disorders, pernicious anemia, alopecia areata, diabetes mellitus, gastric malignancy, and mucocutaneous candidiasis. Investigations. So, you like to obtain a basal cortisol level, and if the basal cortisol level is less than 3 microgram per deciliter, then this will indicate adrenal insufficiency. Some authors also advocate a cutoff point by less than 5 microgram per deciliter. If cortisol levels are greater than 18 microgram per deciliter, then this excludes Addison's disease. If this is equivocal, that is in between 3.1 to 17.9 microgram per deciliter, then a provocative test with insulin, a methylrapone test, or cosintropin test may be used. So in this case, we also have cosintropin or synactin stimulation test. A rapid adrenocorticotropic hormone is administered, and this is followed by cortisol level check. Addison's disease is excluded if cortisol is greater than 550 nanomole per liter. So you'll like to check the electrolytes, glucose levels, get renal function. The white blood count is very important as infection may be a cause of adrenal insufficiency. Now, in the developed world, the most common cause of adrenal insufficiency is an autoimmune disorder. Hence, a 21 hydroxylase adrenal autoantibodies may also be assessed. Plasma renin and aldosterone levels. Regarding imaging, a CT scan, chest x rays may be necessary to exclude diseases such as tuberculosis or sarcoidosis, as infiltrative disorders may also be a cause of Addison's disease. Treatment: admit the patient for IV fluid resuscitation and hormone replacement. Glucocorticoids are started. Fludrocortisone acetate has a sodium retaining effect just like aldosterone. Dehydroepiandrosterone is a weak androgen and may be given if necessary. Treat associated infections actively and promptly, as well as any underlying cause of adrenal insufficiency. Correct glucose and electrolyte imbalance. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.